Welcome to the first of two lectures about menopause. Let's begin with the terms. So menopause itself means the pausing of menses, stopping of periods. The actual definition, and this differs from your textbook, stick with the definition that I have here in lecture, is 12 consecutive months of no periods. And what's happening is we have loss of ovarian function that results in no menses. The perimenopause are the months and years before actual menopause occurs. And so this woman has a history of irregular menses, may or may not have hot flashes, and these hormonal changes begin in the mid-40s. The climacteric is the changes that affect the endocrine system as well as the psychological and physical alterations that occur as a result of loss of reproductive function. And as you see by the cartoon on the right, these are some of the ways that a woman feels as they're going through menopause. Now do note, because menopause is 12 consecutive months of no menses, if a woman is going through menopause and she's gone 9 months no periods and she's rubbing her hands together thinking, yippee, I am finally not going to have periods, and then all of a sudden she gets one, the clock starts all over again. So physiologically, what is going on? There is a decrease in the response of the ovaries to the gonadotropin releasing hormones, and these are abbreviated GnRH. So what happens is the pituitary gland keeps sending out follicle stimulating hormone to try and get the ovaries to respond. And so that's why the FSH is one of the blood tests that we'll do when someone comes in complaining that, oh my God, I'm having hot flashes and my periods are irregular. And we'll only do that FSH in someone that is less than 50 and complaining. So initially, there's sporadic response by the ovaries, which is why they have irregular periods. And then eventually, there's no response at all. And the little chart on the right shows the changes of the hormones. And look, this is spanning 40 years. And so women can go through and have the signs and symptoms of menopause for decades. So what are those signs and symptoms? Well, in a nutshell, it's in this picture that's on the bottom right. And then on the top right is that poor woman who is having what I call her own personal summer moment. So the biggest complaint are the vasomotor symptoms known as hot flashes. Close to 90% of women experience these, and 60% of them will come to a healthcare provider asking for advice on how to deal with them, and can you please give me something to make them go away. In addition, there is disturbed sleep. Some of this is a result of the hot flashes, and others it's just affecting their circadian rhythm. Eventually, there's complaints of vaginal dryness, and this affects sexual activity because they have dyspareunia, which is painful intercourse. Because of the lack of estrogen that supports all of the epithelium, they have urinary stress incontinence. And this can be urge incontinence as well as stress incontinence. And then there's vaginal atrophy. We lose the rugae that are within the vagina. Now these are those temporary side effects. We say short term, but when you look again at that picture of how long a woman is experiencing this, it can be 20 years in the making. And then we look at long-term systemic consequences. And this is due to osteoporosis, and part 2 of this lecture deals with that, as well as heart disease risk. Women begin to lose ovarian function and decrease in estrogen, which has been protective in nature, and then they have the same type of heart disease risks as men. So managing symptoms. We used to do nothing but hormone replacement therapy. When the Women's Health Initiative study was published, and it was published early because of their remarkable findings, and this was in the early to mid 90s, all of a sudden I had stacks and stacks of phone calls from women who had been taking estrogen replacement therapy for a year or for 10 years and calling to know, oh my God, am I going to have breast cancer? Oh, am I going to have this and that? I wasn't even familiar with the study yet, but boy, I became familiar very quickly. So there's actually two, the Women's Health Initiative study and the heart and estrogen progesterone replacement studies that have guided practice. So the American College of OBGYN has developed an opinion paper, and they say use hormone therapy for a limited period of time so that the woman is going through what I call the tapering of the estrogen loss. However, don't use hormone replacement therapy, and we abbreviate that either HRT or ERT, to reduce the risk of cardiovascular disease or events because it has not been proven in studies to actually do this. Hormone replacement therapy does not increase the risk of cardiovascular disease in healthy women in menopause. So if you're healthy and you have no risk factors, there's no reason why you can't go on hormones. And they ask that we focus on that healthy lifestyle. Isn't this a recurring theme in women's healthcare? And it should be in men's as well. So decrease cardiovascular disease risk. Exercise, low-fat diet, low-salt diet, minimal drinking, etc. Improve the quality of life. So stress management and exercise is an excellent means of doing that. And then always perform a risk assessment prior to starting hormone replacement therapy. So we do have options that a woman can decide upon. So there can be systemic, and what this is a combination of estrogen and a progestin if the uterus is still present. If she has had a hysterectomy, then she can use estrogen alone because it's the progestin that was the culprit in causing breast cancer and cardiovascular disease related to HRT. What does systemic combination therapy do? It decreases osteoporosis and it decreases the risk of colon cancer. But the risks associated with it is unopposed estrogen, because there's some women, they don't want to take that progestin because that's that second half, that luteal phase hormone that makes us get PMS. They didn't want to do that anymore. But the risk is they could develop an endometrial cancer. The combination therapy increases the risk of breast cancer. So the medications that you might see when you're doing medication reconciliation upon admission to anywhere that you're encountering women would be Premarin or Prem-Pro. That's the most common, and the Prem-Pro is the combination of Premarin and Provera together. And then there is a variety of patches, so Vivel and Climera, and you will find these when you're doing your physical assessment on these patients. You're going to find a small patch that they usually place on their abdomen because we want it over a fatty area. And they change these patches. Some are once a week and some of them are 2 times a week, whichever one they've been prescribed. For those who don't want to take systemic therapy, we can give local therapy in the form of a vaginal cream, and estrase or Premarin are available. They can also do a vaginal ring, and the ring is replaced every 3 months, so it just stays in place. So you would have to be teaching them about how to insert this ring. The physician is going to hand the woman a prescription, and they're going to look at you and say, teach her how to insert it. Okay? So that's what you need to do. So hot off the press are some other non-hormonal options for controlling the symptoms. So this is stuff that's been published as late as October of 2015. So an SSRI, paroxetine, which is Paxil, but in a lower dose than what we use for depression, taken every day is good for vasomotor symptoms. Whoops, that 60 milligrams a day that I see here is supposed to be for our next drug, which is ospemifene. And this is used for vaginal complaints and dyspareunia. And how this works is it stimulates vaginal epithelial tissue. And while doing this, it spares the epithelium of the endometrium, so we don't have to worry about endometrial cancer. However, the FDA recommends that we add a progestin to prevent the possibility of a woman having a venous thromboembolism. And then the latest one is a conjugated estrogen with bazodoxifene. And so this is another SERM. And they take that daily, but it's only for short-term use. And what this is good for is it reduces bone turnover, therefore reducing the incidence of osteopenia and osteoporosis, as well as alleviating vasomotor symptoms. So when you get a patient that gets admitted to the hospital and you see that she's on ospemifene and she's going to be a surgical candidate, you know that she has a risk of a VTE, and you want to be proactive in making sure she has squeezers on, early ambulation, the same with anybody that's on estrogen. So this ends part 1 of menopause.